Way to go, Limna. All right. So, good evening, everyone. I welcome you all to the DOS Postgraduate Education Series. And as we know, we're in the last leg of our oculoplastics program. And we have one of the most fantastic speakers from the whole program today coming to us with an even more interesting topic, which I think is a little tough for residents to understand. So hopefully the next 40-45 minutes should be very interactive to you very helpful for everyone. I'm very happy to welcome Dr. Tarjani Dave, who is currently a consultant at the LV Prasad Institute, Eye Institute at Hyderabad. She finished her undergraduate degree from the Lokmanya Tilak Hospital, Sai in Bombay, and then finished her post-graduation from the Sri Ganpati Netralaya. She went on to do a fellowship at the LV Prasad Eye Institute in oculoplastics. She's an accomplished academician. She's got more than 60 peer-reviewed publications and chapters, and is one of the biggest innovators in our field today in the country. And she's a recipient of multiple awards, including the Best Poster Award from the AIOS in 2011, 2018, the Best Paper in Oculoplasty in AIOS in 2018 and 90, an International Best Paper Award for Imaging in Thyroid Eye Disease in 2020. She also enjoys gardening, cooking, and the company of her kids. So, without delaying this further, ma'am, I'm going to hand over to you.
Thank you so much, Pallavi. It's a pleasure to be here. Are my slides visible to you?
Yes, ma'am. All good.
All right. So good evening, everyone. And I hope the next few minutes on orbitotomies will take you through the basic understanding of orbital surgery. You will see certain full-face photographs of my patients for which we have the consent in place. And I don't have any financial disclosures pertinent to this topic. I'm going to just make it simple and take you through certain aspects of orbital surgeries. The first aspect I wanted to deal with is what exactly are these orbitotomies helpful in? And in this spectrum, I'll be covering orbital lesions. How do you decide between excisional biopsy, incisional biopsy, or debulking? And how do you approach the orbit for orbital injections that we seem to be giving more and more these days? We also use these orbital incisions for reconstructive surgery of the orbit, like in orbital decompression for thyroid eye disease and in fracture repair following orbital fractures. So just taking you through certain case examples, you see a young gentleman with proptosis on the right side here, fullness in the brow here. Imaging shows you a lesion in the superomedial orbit. This is the sagittal cut of the CT scan. This is a soft tissue lesion, relatively homogeneous, isodense in nature. Now, this sort of a lesion in the superomedial orbit in a young adult is more often than not an orbital schwannoma. And orbital schwannomas need to be excised in toto to avoid recurrence, and sometimes you might have malignant transformation in these lesions. Therefore, an excision biopsy where you completely remove the lesion is recommended. And that is what was done for this gentleman. You can see over here a subbrow approach, some traction sutures in place, and this lesion which has been excised completely with the nerve from which it was arising on either side. So this was an orbital schwannoma on biopsy. Then again, you have another situation here where you see a young girl with a little proptosis and fullness. And if you look at her scans, it is an isodense mass in the entire orbit. It's difficult for you to figure out where the optic nerve is, where the muscles are. In the anterior part as well, it was involving the lacrimal gland, all the extraocular muscles. And therefore, in this situation, what you want is to establish diagnosis, and therefore you'd opt for what is known as an incisional biopsy, meaning you would go and remove a chunk of tissue from this tumor, not necessarily the entire tumor, because you cannot do that. You can't differentiate the tumor from the nerve and the muscles, and therefore you can't excise it completely. So what did we do in this girl? We took a superior eyelid crease incision, as you see over here. And from the superomedial part of the orbit, we took an incisional biopsy. Now, why is that? That is because you see a little isodensity, you see a little fat here, and therefore the tumor is a little distant from the inferior rim. Whenever you biopsy, you want to be at the epicenter of the tumor, and the epicenter actually in this situation is where the optic nerve would be, but you want to be as close to it, and therefore we've taken biopsy from the superomedial area. For the same girl, there are other options of taking biopsy from the medial orbit or the inferior orbit. Just that, like I mentioned to you, you want representative tissue, which is always at the center of the lesion. And therefore, we took a superior eyelid crease approach. She ended up having idiopathic orbital inflammatory disease, for which she was on immunosuppression later on. Now, you also have certain situations where you need to poke a needle in the orbit. And this is also a situation where knowing the orbital anatomy and understanding approaches to the orbit are very important. You see a child here with a macrocystic venolymphatic malformation that looks bluish in color as you retract the eyelid. And all you need is to aspirate the blood from here and inject a sclerosant. And obviously, knowing and understanding from what region to aspirate is important. Another situation of an orbitopalpebral cyst in a child with congenital clinical anophthalmos. Since here the fornix was not formed, what we had to do was aspirate the cyst, inject a sclerosant in it so that the cyst wall collapses with fibrosis. The epithelium is damaged due to the sclerosant, and therefore the cyst cannot reform again. And once that was done, this child has had socket surgery for implant placement, followed by placement of a prosthesis, and has a reasonably good cosmesis. Now, other situations where you want to explore the orbit include treatment of orbital fractures. You see a blowout fracture of the floor on the right side here, and this is the intraoperative view where contents that have been prolapsed into the maxillary sinus below the fracture are being scooped out, and then a plate has been placed, and this is the post-operative radiograph of the same patient, where you see that the orbital floor is reasonably corrected. Similarly, this is a pre and a post photograph of a young gentleman with thyroid eye disease, very obvious bilateral starey appearance. He's had a 4-wall orbital decompression, all via hidden incisions, and therefore you see this beautiful post-operative cosmesis without visible scars in this patient. So now that we've seen in what situations you might want to approach the orbit, let's look at how does one go about approaching the orbit. I've put up certain approaches to the orbit that are used. The most frequent ones in the armamentarium of an orbital surgeon are the transcutaneous and the transconjunctival approaches to the orbit. You can always enter the orbit from surrounding spaces, such as from the maxillary sinus or from the sinonasal cavity, or even transcranial when you combine or team up with a neurosurgeon for lesions that are extending beyond the orbit into the brain. Once the craniotomy is done, you can always expose the orbit from the cranial approach as well, but that's very complex and possibly beyond the purview of what we should be covering today. So I'm going to take you through how I plan an approach for a patient. And I like to divide the orbit in 4 quadrants by 2 crossbars. And based on where is the maximum diameter of the tumor or where is the epicenter of the tumor, I decide what approach to take. So if your lesion is largely in the superomedial quadrant, you have the possibility of using the eyelid crease or transcaruncular approaches. Rarely, you can even do a vertical eyelid split approach to expose this segment of the orbit and remove a tumor from here. Similarly, if your tumor is largely superolateral, you have the approach of using the eyelid crease or the subbrow incisions. Likewise, if your tumor is inferomedial, you can extend the transcaruncular incision inferiorly and remove a tumor from this quadrant. You can also reach this quadrant via a swinging eyelid transcaruncular approach, which can be extended to join the swinging eyelid transconjunctival approach, which can be extended to join the transcaruncular approach. and therefore release tumors from this quadrant. Finally, if your tumor is in the inferolateral quadrant, you'd go again for the swinging eyelid transcaruncular approach. Rarely, you can also use a Berkey's approach where you do a lateral canthotomy, cantholysis to remove a tumor from this segment or to expose this part of the orbit. Now, I'll just make this simple with the help of some schematics that I drew when I was a fellow. This is your sagittal cut of the eye, and that's your lower eyelid. And for simplicity's sake, this is the tarsus, this is the orbicularis. So this is your conjunctiva. When you are taking the inferior transconjunctival approach, you have two options. You can either directly go into the orbit, which is what you are seeing here, where you don't disturb the septum in the lower eyelid, or you can go on top of the periosteum of the lower eyelid, reflect the periosteum, and then enter the floor of the orbit. These are two approaches that are available to you. Both are inferior transconjunctival approaches. In one, you cut through the septum. In the other, the septum is preserved. Similarly, when you're looking at the upper eyelid, you have the option of going directly subbrow. So here you have the skin, the orbicularis, the tarsus, the levator muscle, the conjunctiva, the preaponeurotic fat pad and the orbital fat, and this is the orbital septum. Now you can either go through the skin and orbicularis and go on top of the superior orbital rim, make an incision on the periosteum and then enter the orbit, or you can just bring this incision lower down to go to the eyelid crease so that post-operatively the scar is hidden in the eyelid crease and is not visible. This approach of eyelid crease incision just makes the scar a little more aesthetic. Similarly, for medial orbits, you can go via the caruncle. When you're going via the caruncle, you are in a plane between the Horner's muscle of the eyelid and the septum, which keeps the lacrimal sac protected. And then you go posterior to the posterior lacrimal sac and then go about doing whatever you need to do towards the medial orbit. I'm going to show all this to you via a small skull model where we've used clay for ease of understanding. The green is the skin, the red is the orbicularis. What I've done here is a lateral canthotomy and an inferior cantholysis. And after that, I'm showing you what a transconjunctival incision looks like. You retract the lid with a damer and then take that incision. Now, this is the approach where you are, after taking that incision, going on top of the orbital rim and making a nick in the periosteum, as you are able to see over here. Usually these periosteal incisions are 3 to 4 millimeters on top of the rim, and then at either ends, you can give a relaxing incision, and you can use a forceps and periosteum elevators to lift up the periosteum in that region. What this helps you do is it keeps the extraconal fat held within the periosteum so that the minute you are in the orbit, you're actually on the floor of the orbit. Once you've reached the floor of the orbit, you use two right angles for retraction, a damer to retract the lid, and therefore you can expose the entire floor. Now, this part shows you the transcaruncular incision, where once you've taken an incision in the caruncle, you use a tenotomy scissor, go posterior to the posterior lacrimal crest, and in a hand-over-hand fashion, you kind of expose the medial wall of the orbit. You replace your damer with the lid retractors, and with the help of these retractors, you're able to see the entire medial wall. Now, what I'm demonstrating here is the subbrow incision, where you're taking a cut on the skin, you're dissecting the orbicularis with a cautery, you lift up the orbicularis and dissect through the fat, which is present in the subbrow region, and then you reach the periosteum of the superior part of the orbit. At that periosteum, you are going to take again an incision which is 4 millimeters above the periosteum. You saw that being done with the blade. Medially, you want to stop short of where the supratrochlear neurovascular bundle is. You lift up the periosteum with the help of forceps and a periosteum elevator. And once you've lifted up the periosteum, you're going to enter inside the superior orbit. This approach gives you great access for all tumors that are within the superior, superolateral, and superomedial areas of the orbit. And then you can obviously use two instruments and retract in a hand-over-hand fashion to expose the roof, to expose the extracornal fat, to look at where the tumor is and to tease it out from that quadrant. So this is what you are seeing being done in the superior orbit. Now, one essential part here is to give an incision in the periorbita, which is generally taken as a T-shaped incision. And then after that, you start retracting the structures. I'm retracting the superior rectus muscle there, which was red, using two blunt instruments, a lens spatula and a periosteum elevator, and then you'll be able to see the pole of the tumor, following which you separate the tumor from all directions and release the tumor from its attachments and finally deliver it. So this was just a clipping of showing you how, a schematic way of showing you what is done in orbits. Now with this, we'll go through certain surgical videos. This is a gentleman who has right proptosis, as you can see. Imaging shows you a well-defined intracornal lesion, which is resulting in axial proptosis. It is a little heterogeneous. This lesion is displacing the optic nerve medially and inferiorly compared to the optic nerve on the other side. So therefore, if I draw crossbars in this orbit, most of the tumor is superolateral. So the options available for me at this point of time would be an eyelid crease or a subbrow incision. This is again the MRI showing you how closely this one part of the tumor is sort of hugging the optic nerve. And these are situations where surgery is extremely challenging. Any damage to the optic nerve in an attempt to separate the tumor might result in permanent vision loss. This is the same patient. We've taken a skin incision. I'm now dissecting the orbicularis with a radiofrequency cautery. This is an eyelid crease incision, and therefore you go suborbicularis till the roof. Now, this is that part which I was showing you where you take an incision on the periosteum of the superior orbital rim. You stop your incision just short of the neurovascular bundle, which is likely to be in this location, and you give two relaxing incisions at either end of this periosteal incision. This is where a forceps and a periosteum elevator is being used to peel off the periosteum from the roof of the orbit, and there you are entering within the orbit. We're now using malleable retractors to retract and right-angled retractors to hold the fat and the muscle out of your way. With this, blunt dissection is initiated, and you can see that purple tumor peeking over there, and we are trying to separate it from all its adhesions all around so that when cryotraction is applied to it, you're not pulling out unnecessary structures or you're not damaging the optic nerve. That was a hemangioma. Once delivered, the periosteum is closed. This is done with absorbable sutures. This is a 6-0 vicryl suture, which is being used in multiple layers to close the periosteum. The purpose is you don't want the skin and to get adherent to the bone there. So you want a soft tissue cover. And once the periosteum has been closed, the skin incision is also closed with interrupted vicryl sutures. This was the patient preoperatively with the proptosis. I showed you the imaging earlier. And this is him post-operatively. And you can see that that scar is nicely hidden in the lid crease. And therefore, this is a minimally invasive or an aesthetic approach to remove an orbital tumor almost as large as the globe. Now, let's look at another situation. This is a gentleman. You see a little fullness here. He's quite young. He has a pulsatile lesion, which on imaging is an arteriovenous malformation. So you can see this entire black area here. That is the arteriovenous malformation. If you look at the angiogram, you can see the malformation in this region. And this was a patient who had a percutaneous glue embolization of the arteriovenous malformation under angiography guidance. immediately before we took him up for surgery. So he's had embolization, and following that, I have taken him up for surgery. I've marked the feeder vessel where I felt there was some pulsation, and then I've marked the extent of the lesion. This is the subbrow incision that I have marked, and I'm injecting local anesthesia in that region to kind of keep the bleeding as minimal as possible. In vascular malformations, you should expect a significant amount of bleeding. We've done a percutaneous embolization just to reduce the bleeding so that surgically you can visualize the entire malformation and excise it in toto. So we've taken the skin incision here, and under the skin, you're seeing the orbicularis, which has been dissected. Once the orbicularis is dissected, a combination of blunt and sharp dissection is used to expose the entire tumor. And now I'm going underneath the tumor and releasing it on both the sides, both the poles of it. We've already dissected above it. We're dissecting underneath it. The undersurface is adherent to the periosteum of the superior orbital rim. This is the entire malformation that has been excised. You can see it over here. I had put a traction suture at one pole for identification for the pathologist, on which side is medial and lateral. And then a few interrupted sutures because the tissue in the brow is thick. You cannot suture in one layer. So we had taken vicryl sutures underneath, and then the skin has been closed with a 6-O-proline rulling suture, as you see over here. So this is him post-operatively, and you can see a reasonably good scar cosmesis. The incision has to be planned in such a way that it is hidden in the brow hair, and therefore spend those extra couple of minutes planning your skin marking before you take your incision. Let's move on to the next case. Now, this is a lady with left proptosis, as you see over here. The bird's view gives you a better idea of the amount of proptosis, which is very significant. And this is her with a large tumor in the orbit. In fact, the tumor this is the optic nerve. So it's kind of going into the region beyond the optic nerve laterally, inferiorly extending almost till the floor of the orbit, superiorly involving the entire superomedial orbit. With these tumors, again, let's do the crossbar. So if you do the crossbar here, where's the epicenter of the tumor? Superomedial quadrant. So what are your options? Medial eyelid crease or subbrow, or you can think of taking a transcaruncular, extending it superiorly, but then look at the size of the lesion. To pop out a tumor which is as large as the eyeball or larger than it from a transcaruncular incision is not possible. The space there is very limited. So what we thought of doing here was a vertical lid split incision. And this is how it's done. You mark the lid in the medial quadrant and you create a surgical tear in the eyelid. Through this incision, you can directly enter the intraconal space. And this is what is being done. The traction sutures have been taken to hold the two ends of the lid away. We are entering the intraconal segment. The tumor actually was all around the superior oblique muscle, and we had to incise, or we had to cut the muscle in order to be able to deliver the tumor completely. You're seeing cryo being used over here, and with cryotraction, we were able to remove the tumor and the attached nerve that I just showed you there. This was again a schwannoma. Once the tumor has been removed, the two ends of the superior oblique that we had cut are being reunited and were secured in position. And then the surgically created eyelid tear is being sutured just the way you suture any other marginal eyelid tear. You do the posterior lamina first, and then you do the anterior lamina. Here I've tucked the levator muscle also on the tarsus. That's what you're seeing being done under the fat. That was the levator muscle, which I tucked on top of the tarsus to reattach it. And this is the closure of the skin incision with interrupted suture. So this was a lady who had this large intracornal superomedial mass, which has been excised via a lid split approach. Now let's look at yet another case scenario. This is a young girl who's very concerned with the left enophthalmos that she has. She has a little scar here, if you can see. She's had a fracture of the orbital rim which has been treated, but the floor and the medial wall component wasn't addressed, and because of that there's volume expansion, and because of that the left side is enophthalmic. So the medial wall is fractured, so is the floor, and we decided to put an orbital plate. So what we are doing over here is a swinging eyelid incision where you do a lateral canthotomy, cantholysis. This is where you're going on top of the periosteum, releasing the periosteum, retracting the tissues, exposing the area of the fracture, bringing out all the prolapsed tissue into the orbit, exposing the medial wall. Now I just want to pause for a bit over here and show you. This instrument here is a nasal endoscope, and many times we use this just for better visualization of our dissection. So while I'm operating here, I'm actually looking at the screen of the endoscope to understand what exactly is the tissue that I am handling and what are the extent of, what is the extent of the fracture, where is my plate sitting. So this is an adjunctive tool that you can use. Now that asterisk there was the posterior ledge. You can see it over here. So just to give you a better understanding, this is the maxillary sinus. This is the malleable, which is towards the surgeon. You are retracting the orbital tissue towards the malleable, and you expose the posterior ledge of bone on top of which you want your implant to sit. So using the endoscope just makes it better for you to understand where exactly to place the plate and whether your dissection has been sufficient or not. The blue thing that you saw going in is actually your titanium plate. And then once I've placed the plate inside, I'm introducing the endoscope to check if it is sitting on top of the ledge. The plate should not be prolapsing into the maxillary sinus. And once I've confirmed that it's sitting on top of the posterior ledge, you put the foot plates of the titanium plate in position. You check your force duction test. Once you feel that everything's been released, you can secure the plate with the help of screws. You close your conjunctival incision with buried interrupted sutures. And you remember you had done a lateral canthotomy and inferior cantholysis. So you take the lid back and put it in position so that you don't have post-operative eyelid malposition. So this girl was, as I mentioned, she had this enophthalmos, which bothered her. This is her about 4 to 6 months post-operative. There is a little residual enophthalmos, but she's certainly much better than what she began with and is quite happy with the outcome. Similar such patients where there is a large tumor with extreme proptosis. This was a tumor which was almost 4 times the size of the eyeball. And I'll just take you through sequential pictures. We had done, since this tumor was largely in the inferior orbit, you see a swinging eyelid incision here, dissection to sort of release the soft tissue over the tumor, use cryotherapy to give traction to the tumor, delivery of the tumor, and then suture to reconstruct the eyelid and put it back in position. Now, this is yet another patient where you are seeing right abaxial proptosis, and this is his scan. So this patient has a diffuse sinonasal and orbital involvement. We were suspecting a fungal granuloma, and therefore versus a sinonasal malignancy. And therefore, what you do in this situation is just an incisional biopsy. So here you see the transcaruncular approach being taken. Remember, I'd shown you in the schematic that you introduce a scissor to go posterior to the posterior lacrimal crest, and in a hand-over-hand fashion, you dissect tissues in that region to expose the lesion. This white gritty part was where the lesion was. There were certain adhesions over it which are being divided, and then cryo is being used to give traction, and a blade is being used to take an incisional biopsy. At times, we use a combination of blade as well as scissor. This is the part of the lesion, of the gritty lesion that we've removed. We wanted to send some tissue for microbiology, and that's why that little excuse me, chunk of tissue was removed. Microbiology did tell us, and frozen section told us it was fungal, and therefore we injected voriconazole before closure. And this is just a single suture taken on the caruncle to bring the tissues back to apposition. So this was the patient in whom we've taken a transcaruncular approach. So I've covered the different surgical approaches with the help of surgical videos. I'll just take you through certain cases, and then we'll open it up for questions if there are any. This is a young child with left proptosis, and you're seeing a dumbbell dermoid here. And in this child, this is the post-operative picture. So if you see a dumbbell dermoid, it's a superomedial lesion, superolateral lesion along the frontozygomatic suture. What are your options? You can either take a subbrow or a lid crease like we discussed. In this child, we took a lid crease incision and we were able to remove the orbital part of the dermoid, curettage the temporal fossa part of the dermoid, and be done with it. And he remained recurrence-free for a long period of time. Now, here is again a dumbbell dermoid, but what we've done differently here is we've taken a subbrow approach. You see this post-operative picture with the scar, but we've done what's known as a deep lateral orbitotomy. What is a deep lateral orbitotomy? You expose the superolateral orbit the same way as we discussed the subbrow approach, and then you remove the zygoma. You cut through the zygoma at the superior and the inferior ends. You make a full thickness osteotomy in it. And when we made that full thickness osteotomy with the bone, we were able to remove the entire dermoid cyst. So that is what was done for this gentleman. And we were able to achieve an excision biopsy in toto for him. Now, this is yet another dermoid. This is the internal angular dermoid where a Lynch incision has been used. If you do that, you are likely to have visible scarring. What could have been done and what would have been better would have been a medial eyelid crease incision. And the same incision could have been used to form the eyelid fold in the medial region post-operatively for this patient. This is a girl with a ruptured dermoid in the lacrimal gland. And again, here we've used a subbrow approach to just take an incisional biopsy because the imaging was not very, consistent with the dermoid cyst simply because it was ruptured. So we did an incision biopsy. It showed that this was a dermoid, and then we had to go back in and complete an excision biopsy for her. This is yet another dermoid cyst. And what's funny here is, yes, she again has a dumbbell dermoid, but this dermoid is completely situated in her lacrimal gland. This is the normal lacrimal gland. This is her lacrimal gland where there is a cyst within the gland, and you can see that yellowish appearance of the gland. Her 3D imaging was very interesting. You could actually see the aperture through which the dumbbell was a dumbbell dermoid. So it's a dumbbell because there's a component here, and then there's a component in the temporal fossa. And for her, we did a Berkey's, and that's a lateral canthotomy cantholysis incision. We were able to expose the lateral orbital wall. This is the lateral orbital wall with that aperture through which I've passed a periosteum elevator, and we were able to excise her dermoid completely. And again here, this is her post-operative appearance with that little scar in the lateral canthal region. Now, this is a patient with a fracture. So what approach would you take? He has a floor and a medial wall fracture. So obviously you'll need an inferior approach as well as a medial approach. So what was done over here is a swinging eyelid incision, and then a plate was placed to correct the hypoglobus as well as the enophthalmos. This is him post-operatively. You can see that the eye that was in hypoglobus has now come back in position. This is his post-operative imaging where you can see that the plate is nicely in position and has brought back the orbital volume to match the contralateral side. Sagittal reconstruction showing the plate and 3D imaging showing the plate in position. And this is him 5 years later, still showing a beautiful correction of the fracture and not having any eyelid malposition despite the conjunctival incision. Similarly, this is a lady who has an inferior intraosseous hemangioma. And for her, there was no way we could remove this via a conjunctival approach, and therefore we had to take a cutaneous approach. So this is a subciliary approach through which we've exposed the hemangioma, completely removed or excised the hemangioma. And what I'm doing over here is just trying to make a template of the using any tool that you have. I'm just using the wrapper of Vicryl here, and that template I've used to mold an absorbable implant. In this situation, this is osteomesh or PDS implant, which is folded into position to reconstruct the orbital rim, put in there to reconstruct the orbital rim, some fat put on top of it, and then the skin was closed. And this is her about 4 months after the surgery, looking much better than where we began. With all these surgeries, what else do you need? You need the ability to be able to approach the orbit via other incisions. For example, this gentleman with a fracture and a symblepharon, the lid is stuck to the cornea, it's not moving up, and therefore he also has leg ophthalmos. He had no orbital rim. He has plates which have been put, but then he had a large floor fracture and no absent orbital rim, which we had to reconstruct for him. So what we've done here is used a Cadwell-Luck approach and taken a gingival sulcus incision, exposed the mandible. This is his maxilla. This is his mandible, lower teeth. We've taken a graft from the mandible region and then use that to reconstruct the inferior orbital rim, over which the fracture is corrected with a titanium plate. This was him preoperatively. We put that mandibular graft here and then put an orbital titanium plate over it. And this is him post-operatively, where you see that the eye has come up. We've used an MMG to kind of take care of the symblepharon, which was there between the cornea and the eyelid margin here. And therefore, you see this red tissue. This is him early post-op. This MMG is now thinning out and he's doing much better. I'll skip through this case, which is a similar case where I wanted to demonstrate that this patient had, again, just reconstruction of the rims, but absolutely no floor present. We wanted to place an implant, a spherical ball implant also for volume correction, over which we wanted to give a prosthetic eye. But since there was absolutely no floor, we had to reconstruct the floor. Now, to put these implants in, not only is a conjunctival incision needed, but to make this part of the maxilla, a gingival sulcus Cadwell-Luck approach is also needed. And all these incisions come in handy if you learn these skills or you team up with oromaxillofacial surgeons for the care of such patients. And you can see that he's had an evisceration along with correction of the maxilla and the floor fracture. And this is a prosthetic eye. Doesn't look great, but certainly looks better than preoperative picture. Certain other things that you have and you need are very good illumination. This is a picture from my fellowship days where we've used a right angle retractor with a light source. You can do this for deep lateral wall, access to deep lateral wall and decompression there, or even to release tumors, where actually using a light right inside the orbit makes it better. In the absence of this kind of fancy equipment, you can just use a simple endoscope, which has a light source connection, which will also give you illumination. Or you can use your surgical loops that have inbuilt light, which will also help you have better visualization intraoperatively. You, in many orbital tumors, will need cryotherapy for easy delivery of tumors once you've released all the adhesions. And this picture is just a reminder that there are several hands that go into making an orbital surgery successful. These are all trained hands of all the people who assist us, from our fellows to our nurses in the operating theater. And it takes a lot of effort to successfully perform an orbital surgery. Orbital surgery comes with its own complications. The most devastating, obviously, is vision loss. Functionally challenging are diplopia and ptosis. CSF leak is rare but can happen. And sometimes you might have enophthalmos after you've removed or excised a large orbital tumor. So that is what I had to share today with all of you on orbitotomies and orbital reconstruction. I'm going to stop sharing here and I'll be ready to take questions, Pallavi, if you have any for me.
Thank you so much, ma'am. That was such a wonderful lecture, especially for me to watch, because it was like seeing Dr. Gutman's book out in, it was like seeing a practical version of that, just the videos and the case presentations. I think I thoroughly enjoyed it. I think very helpful. Of course, for the residents, but also, for fellows and practicing oculoplastic surgeons. I think this is one lecture for the books, really, really helpful. Just one, I mean, there's a couple of questions from the point of view of residents, but one question from my own end is when you were talking about these approaches, when we do these fractures, like you talked about Calvin Luck, do you typically do all of these on your own, or do you work with plastic surgeons or maxillofacial surgeons, or how does that usually happen?
It's a great idea to team up if you can find that kind of collaboration over a period of time. It's also a great idea to learn these approaches. There are very many surgeries where it's always good to have that knowledge of anatomy and the soft tissue. It does go a long way in you being able to perform that surgery better, predict complications. So whether you do it on your own or you team up is something that is decided with a multitude of factors. If you have people with whom you can easily team up, so be it. It's the way to go. If you don't have people where you don't have a maxillofacial person visiting you or a plastic surgeon visiting you, or you are in a standalone eye institute, many times you have the requirement to learn this. You can always go ahead, learn it, and then apply it for your orbital diseases.
No, it was just such a pleasure to watch. One question from the point of view, I mean, just from the exam point of view, because all of these surgeries that you had shown were beautiful, but I think this for the residents as a step, and all of the surgeries you had shown us were so bloodless, and that's like a surgeon's dream. But like, if if one were to talk about hemorrhage control or hemostasis during the surgery, is there any stepwise approach just from the point of view of answering in the exams, that conceptually what are the things that we should be looking at, especially with orbital surgery, you know?
Yeah, that's a great question. So it begins preoperatively. You should know your patient well. So systemic risk factors such as hypertension, uncontrolled, would need good control. If it's a tumor and you're in a urgent need of operating, you can always reach out to the physician or the cardiologist and express to them the need for urgent surgery, and they can tweak the antihypertensive drugs to give you good intraoperative BP control. The second part, and this is a part of history I ask every patient, irrespective of whether they have cardiac history or not, is whether they are on blood thinners. It's extremely important. More and more patients have been on blood thinners following COVID, and you can have devastating bleeding within the orbit. If it bleeds within the orbit, you're in trouble. Controlling that bleeding in a tight space can lead to difficulties, compartment syndrome, and vision loss. So these are two parts of history that I certainly ask every patient, whether they have hypertension and are they on blood thinners. During the surgery, I insist that many times what happens is, and these are simple points, that you say that you have to be fasting before the surgery for GA, and then they don't even take their antihypertensive medication. So I tell them that with a small sip of water, take your antihypertensive pill on that day. During the surgery, I'm always in communication with the anesthetist to give me hypotensive anesthesia, which means they give me controlled low blood pressure, which is safe for the patient, but also makes my job of delivering a tumor much easy. Few other things like, raising the head end of the bed, using tumescent anesthesia, in certain situations are other ways of controlling the bleeding. If at all you are able to see large blood vessels, which are insignificant, then you can go ahead and cauterize them very gently in the orbit. Cautery in the orbit is a double-edged sword. So you can certainly go ahead and cauterize them. Use a bipolar, because then the current is only between the two prongs and cannot vertically enter or cannot be transmitted to other soft tissue in the orbit. Don't use a monopolar in that situation. So cauterize that blood vessel if you can see it before you proceed with your dissection. If at all, after all of this, you've had a blood vessel open up, then you again need to go stepwise. The first thing I would do is take a piece of gauze and dump it into the orbit and give indirect pressure, not direct pressure. so that pressure again has to be monitored. You don't want the optic nerve dilating just from the pressure that you're giving, but give that indirect pressure so that the bleeding stops. If you just wait for about 5 to 7 minutes and you go beyond the clotting time of the patient, most bleeding tends to stop. Sometimes as you withdraw the gauze piece, you'll have that vessel open up and squirt again. And if you're able to visualize it, then again using a little bit of cautery. Here I would go use a forceps to grasp the bleeder and cauterize it with a fulguration tip. If it's bleeding from bone, then again you have the option of using bone wax. If it's bleeding from soft tissue, you have the option of using Surgicel or Abgel, which are other available modalities. Sometimes you can use tramadol soaked in your gauze to just control tranexamic acid soaked gauze to just control the bleeding in that region. I typically don't like to use adrenaline soaked gauzes to control bleeding, but this is the entire gamut of things available to you for controlling bleeding.
I think that's very helpful, ma'am, because I think that's it's one of the practical issues that we face. And also, I think it's very important to have a stepwise approach for these patients, or intraoperatively, even like IV infusion or any of these things.
Say that again, Pallavi. Did you ask me intraoperatively any other adjuncts?
Yeah. No. So I was asking if you like to use tranexamic acid
Yes, you can
for any of
always.
these patients
Yes, I would ask my anesthetist to start the patient on tranexamic acid, ethamsilate, if whatever it is for controlling bleeding, IV intraoperatively, if on table none of these measures help. If it's a large arterial bleed, you also have to be ready to kind of ligate, figure out where the artery is and ligate it. I don't really remember having to do it except for that arteriovenous malformation case that I showed, where I had to ligate the feeder vessel, which was not completely embolized. So I've rarely done that.
those are such challenging cases to manage. One more question, ma'am. In cases where you look for, margins is one thing I wanted to ask about. Sometimes when we have malignant tumors, or even tumors, say solitary fibrous tumors that might turn out to be malignant on histopathology, do you routinely take margins? Because for islet tumors it's fairly simple, you can send margins. But what is your thought process, and or how do you approach these things when you're looking at tumors,
So I
margins
don't,
intraoperatively?
I don't take margins for orbital tumors, but I ensure that for well-capsulated tumors, those that have a very well-formed capsule, an encapsulated tumor, I don't breach the capsule. So I perform my surgery in such a way that there's no breach in the capsule. I'm very careful in dissection. I use a periosteum elevator and blunt dissections with lens spatulas to kind of, separate the tumor from the surrounding adhesion and then deliver the tumor. I think, is my network poor or is Pallavi's network poor?